I'm going to pile on to some of the things that Bob said, but I think I have a little bit different perspective because I want to protect the specialty of emergency medicine. And I think we're at a pivotal point. How many ED volumes are staying the same or maybe going down of your ED volumes? My ED volumes staying the same now. You're going way up still? Are you in a fairly new area though? No? Okay. Across the country, ED volumes are now starting to slide down a little bit. And in the southeast, they're down about 8%. And that's because there's a large variety of practices out there that we're going to talk about that I think, for us in emergency medicine, some of the things Bob just mentioned, and even, getting into the workplace. We actually do the workplace at our Volkswagen plant, as an example. We've got to start thinking outside the box, because there's a lot of things driving this, and I already mentioned value-based care and cost. But where the cost shifting is not only to the hospitals and the providers, who also is getting the cost shifting? The payer, right? The patient. I mean, their deductibles are going way, way up, and they're looking for value. So we're also in a new age of digital disruption. And I think this is going to affect the emergency department. And, I listed here, you have my slide, so it's not going to be as neat as I thought this slide might be. But the largest taxi company has no taxis. And who is that? Uber. All right? The largest phone company has no telecommunications infrastructure, Skype. The world's most valuable retailer has no inventory, Alibaba. The most popular media owner creates no content, Facebook. The world's largest movie house has no theaters, Netflix. And the world's largest software vendors do not write their own apps, that's Google and Apple. So the world's changing, and how we are doing things, how we are going to be practicing medicine and emergency medicine in the future is going to be different because it's a new digital age, and this is what consumers want. They want many choices, digitally enabled, options with price. Price is going to become an important component. Visibility through delivery of care, service on demand, 24/7, digital, telemedicine, extended hours of access. Bob already touched on that. But that's what our consumers are wanting. And even as the newer generations, again, sit on their phone the whole time, they're going to want this digital age. And we're going to have to start looking at how in emergency medicine do we provide that. Population health, it is not going away. Population health is managing a population of patients at the lowest cost. It's basically trying to keep them well for the lowest cost. And it's taking all the patient data, payer data, it's taking your risk stratifications, your predictive metrics, your practice guidelines, and it's putting it through a continuum of care, of which emergency medicine is part of that continuum. But it's not all end-all be-all, and we cannot be a standalone island of emergency care anymore. We will lose our specialty if we do that. We will lose our patients. We will have, people controlling what we do to a much greater extent. So we've got to be part of this. I've been saying this since I was president in 2010. We've got to be part of an integrated neighborhood. And it's even more critical as more technological innovations occur. So clinically integrated care, there's basically 4 pillars. One is a collaborative leadership. Then they're going to align incentives with physicians and hospitals. They're going to develop clinical programs, which is going to have, again, a very care protocol-driven clinical metrics, quality metrics, population health management, and then there's a very large technology infrastructure that has to be part of that. Most of us are starting to work here, all right? Some of you are down here, but a lot of us, some of the really advanced ones are really using their health informatic technology to manage populations. They are going to really work hard to keep people out of your emergency department. So we're going to have to find ways to embrace that, ways to participate in that. Otherwise, our volumes will go down. And I know Rick Bucata is giving a talk on the last day. That sucking sound is your low acute care leaving your emergency department. Well, for a lot of you, maybe you don't care because those are your toothaches that don't pay, but for a lot of people, that's your margin of your emergency department. So we've got to find ways to integrate into this new care. And really, the objective for most hospitals, as Bob just says, best-in-class and patient access. All right? You're going to want increased loyalty, improved quality, improve patient satisfaction at a reduced cost. Again, value equals quality divided by cost plus service excellence. You're going to want to improve all that. But in order to reduce cost, you are going to have to become much more efficient, much more engaged, much more helping manage those patients more efficiently through the healthcare system. All right, so population health is staying around. $50 billion last year, just in merger and acquisition activity. How many of you your group has been acquired? Anybody? A few of you have been acquired. How many your hospitals acquired other groups? Probably most of you. I mean, my hospital's buying up all kinds of groups right now. How many of your hospitals have been acquired by another hospital? I mean, this is going on and on and on. Consolidation, merger acquisition to push population health. Again, with economy of scale, the theory is, at least, that you can do medical care more efficiently. Again, trying to improve quality and the patient experience while reducing cost is going to require efficiency. And retail care goes mainstream. I'm going to differ with Bob a little bit of this. I think hospitals are going to have to get into the retail and maybe even emergency medicine because it's not just about the care anymore. But retail care is going to go through the roof. The growth is going to be, there's going to be over 3,000 clinics by 2016-17. They're staffed. They have a limited menu of things that they can do. All right? But they're important for a lot of different things, primarily for the population health management. I'm going to show that. But retail is going to grow. CVS is, still the number one. Walgreens is second. Walmart's coming up. Target. You're going to see more and more of these, or you're going to see partnerships with urgent care physician groups to do some of this. Hackensack's already signed with a large urgent care group. You're going to see more and more of this as it comes. So why is this important? Well, number one, and if this doesn't make you cry, I don't know what will. Consumers, percent of consumers who would trust this energy to manage their health. Walmart, Target was number one. Healthcare providers were two. And this was a recent study by the Camden Group in 2014. All right, Google was 33%. I mean, this is an issue. I mean, we've got some issues to deal with in terms of taking care of people for reduced costs and making sure that they believe that we are taking the best care of them. Sorry. And here's what's the real issue about retail medicine. It is not necessarily the care. The care is over here. So you can do consumer-centered care. And for a lot of the Walmarts, Walgreens, it's to bring patients in. They buy other things. That's a portion of this. But there is another portion. There's a Walgreens, like Walgreens has physician support. So now they partner with physicians to refer patients to. It is a business model. And they are now creating wellness centers. They're helping reduce the gaps in care that they can make money on. And then with population health, there's this whole back office data component where they are collecting that data and they're going to sell that data to healthcare entities so that they can manage populations, so they can identify populations at risk. Because that's what population health is about. And retail medicine is going to become a large component of population health. It is what the people want. It is reasonable cost for people, and they're going to start using it not only to partner with physician groups, and hospitals to refer patients in a legal way, but they're also going to use that data for a back-end office, and it is going to become more and more important. So as an emergency department, you may start working with your hospital, some of these retail. You want to be the provider of choice. Maybe you don't want to do all these health screenings, but you want to be in this second level, and you certainly want to get access to that data if you're a hospital. So we are going to see partnerships. You're already seeing partnerships with these large entities. So again, I've talked about this over the years. The ED cannot be an island. If we're going to be an island, we're going to lose our specialty. All right? We're going to be told what to do. We're going to be told what to charge. It will be more than the death of the Democratic group, in my opinion. We have to be a bridge. We have to be a portal to an integrated care network. And we're going to have to use other technologies to help with that. Again, we do have access to 130 million people. And we've got access to their visitors. So we need to use that time to help manage care. We should be doing education. We should be helping manage their care. We need to get them into a medical neighborhood. We can look at prevention, wellness, disease management. All these things are things we need to step into to a much greater extent, being part of that integrated network. And I think palliative care, geriatric care, which I know is not the same as palliative care, but geriatric care and palliative care are, again, going to be two big areas that I think we as emergency physicians need to step into in the future to help manage cost. And patient handoffs are going to become important. So you want to transform the ED into delivering agile and coordinated care. And so, we've talked about these: fostering input, having capacity protocols, strategizing observation, patient management. Now, what Bob was talking about in terms of, having just an observation area where you put everybody, which is basically a holding unit, that is not what we're talking about. We're having defined clinical care protocols with observation management that can be done for lesser cost, quicker, get them out, because the more they stay in, the more resources and the less cost-effective that care is, I have no doubt. But we need to be a part of that. Hardwiring continuity of care, so having handoffs. Many of you, we've talked about this, having a note now, a standardized form for your skilled nursing facilities, your nursing homes, transferring to psychiatry, working with them to develop protocols. And again, managing high utilizer populations. Bob alluded to that. Care coordinators. How many of you have care coordinators now in your emergency department? Patient navigators to help them get through the system. All right. Most of you are looking at that. Again, that's trying to manage populations more efficiently. And we'll talk about that. What we're seeing, though, so retail and urgent care is probably taking another 150 to 200 million visits now. Probably more than ED visits, urgent care and retail. All right? So what are we seeing in the ED? We're seeing sicker patients. All right? I mean, now the number that have 4 more chronic diseases, coming up to about 40%. So we're going to see a sicker, older population. These are going to need to be managed much more efficiently, or they're going to keep coming back, and costing the system. So the observation unit we talked about, it's got to be run 24/7. I'd run under emergency medicine. I'd have very strict criteria, whether it's a CHF, a chest pain rule out, asthma. I'd make certain diagnoses, maybe abdominal pain, but you want to have strict guidelines because it can become a revenue generator. It can help if it's done right. If it's not done right, if it's a holding unit, then it's not helping anybody, and it is costing the hospital money. But the key is turnover. If you can turn over patients sooner than you admit them under an observation status, you allow more inpatient capacity that has a higher margin, your surgical patients, your critical care patients, greater capacity to offload ED volume, and you lower your fixed cost per patient. But again, you have to do it efficiently. You have to have protocols in place. And a lot of this is also being driven by inpatient criteria, which is getting narrower and narrower. I mean, I have to sign twice now for the type of bed I want. I put it on the top of the order. We write holding orders, and then I have to confirm that I agree that this is either an observation or going to take 2-day inpatient. And it's becoming narrower and narrower what we can admit. So we're going to have to look at efficiency, because observation, I can tell you, an observation admission, especially a Medicare, Medicaid, loses money for your hospital, no doubt. So we're going to have to be part of this solution with our hospitals. We're going to have to enhance our value, not just as acute care providers, but as helping manage populations. It's a different mindset, but I think we're going to need to. Otherwise, we might as well start trimming down our ED residencies now, because we're not going to need as many. If you just want to take care of acute, critically ill patients, we're going to still have those, no doubt. But our role is going to become much smaller. Transitions of care. I know most of you are working on transitions of care, having a patient handoff. Most of you use an SBAR or some sort of, we've taught now it's part of our medical record. We use an SBAR. We have to document it in our electronic medical record. Dealing with skilled nursing facilities, dedicated follow-up referral specialist. Any of you have a referral specialist or even a follow-up clinic? Anybody in your ED? Well, don't be surprised if we start looking at this. This is, again, what EDs, yes, they are expensive, but all their costs are fixed costs, all right? So if you're not doing anything, you could have a clinic, or if you had space, I'm not saying all that's easy, but if you've got capacity to have a clinic on Saturdays and Sundays when nobody else is, that's probably cheaper than opening up your family medicine clinic. So we've got to start looking at that. Centralized follow-up, and again, geriatric focused. So the SBAR, this is a handoff form, describes a situation, kind of the background information, what your assessment is, and any recommendations. And again, most of your errors, most of the increased costs occur on handoffs because we don't know what happened. And often that provider's gone. Sometimes you don't have that data, it's not in the record yet. So this is an important part to helping not only provide quality and patient safety, but reducing cost. So outpatient transfers, that transition of care from the ED to the outpatient is where I think we can make a lot of improvements and enhance our value. I think retail care may help in some ways, but I also think how we transition into the outpatient is going to be important. So we can help decrease costs for chronic care. And again, most of you have already said, you have case managers in your ED. We have case managers. We actually have health coaches now that will work with certain diagnoses, such as CHF and COPD, that will go out to their homes from our ED. We now have a patient navigator program, and I'm going to be presenting that data at SAEM in May. But we're finding that it is reducing costs for our frequent utilizers. You can identify your top 200-300 patients, and that come to your ED in terms of cost, they spend an exorbitant amount of cost. And most of you can probably name the 200 off the top of your head because you see them almost every day. If you can work with those people, you can save a huge amount of money for the cost of 1 or 2 navigators, which is about $100,000. But we're finding we're going to probably end up saving about $3-4 million with our navigator program. So it's an important aspect. Post-ED care. I think trying to arrange that, we've used a navigator, but it requires not only syncing up with your clinics, there's a lot of community resources that aren't being utilized as fully. So whoever's navigating your care coordination units really have to look at what are the whole services that are available to your patients. We work with our federally qualified health center. We work with we have a homeless clinic, medical clinic. There are a lot of things that we work with our psych institutions. We've got to help close the loop, not only primary care physicians, but sometimes getting them into a place where they can get standard their medical care. outside of just an emergency department. So securing timely follow-ups is having clinic schedules. Now we're moving towards electronic scheduling of clinics, visits, but it's a system, and we need to participate in that. Follow-up appointment, some have a specialist. At Stony Brook, they're actually using a clinic where they will do follow-ups. Your suture removals, your CHF follow-ups, your cellulitis abscess management, things, the abdominal pain that you're concerned about. They will follow them up in the ED as a lower cost. It's not an ED cost. So there are ways that you can fit into this model. Decreased cost for chronic care. Well, we've already heard telemedicine is going to become more and more important. You know, whether it's daycares, we have a big prison contract, so we're going to start looking at that. You know, we all have certain nursing homes that continually send you patients, usually Friday afternoon. And so we need to, you know, we're looking at putting telemedicine in there. Telemedicine is not a panacea. Telepsych, for example, is not a panacea for everybody, but it can be helpful. You know, the next generations of Medicare shared savings programs, telemedicine will be reimbursed. So you are going to have these on demand for your patients that are going to want to, you know, talk with their physician. They're going to be tele-ED, where you're going to be talking with maybe your rural ED and making some decisions on resource utilization. ICU is already there in a lot of different ways. We're going to see more and more of this. This has been kind of constrained because of reimbursement concerns and credentialing concerns. Well, the government's starting to work this out because they see the value of this. So I think this is going to be an area that's really going to take off. Decreased cost for chronic care. Again, how many of you use community paramedics now? A few of you. This is, again, a program where you send out, you know, community paramedics. Some are even volunteers, looking at your patients that are sent home with CHF, you know, your frequent flyers, COPDs, checking on them, making sure they're taking their meds, weighing them to see if they, you know, are gaining weight, retaining more fluid. This is, again, a more preventative approach that can be used and is being used out there. So again, a lot of different paths to creating a positive image in the community. Some are using online reservations. Anybody using online reservations? So some are. And it's, again, it's a way to meet the demand of the population. Some of that online will probably be telemedicine in the future. You'll have a telemedicine consult. Patient navigators and care coordination, I think, clearly most EDs are looking at these. Comfort rounds, again, trying to establish that patient experience. That's the one thing I do as a emergency physician is I bring warm blankets to my patients. Number one, because my hands are cold all the time, so I get to hold the warm blanket. But it's a nice thing to do, and patients appreciate that. And Patient Satisfaction Academy, whether it's an internal, your institution has it, I think it's important to, you know, looking at improving the patient experience, helping that hospital with their HCAHPS scores, improving your patient experience, being part of that care integration, is keeping people within your system, keeping them active, engaged, and being part of a coordinated system of care. All right, I'm just going to finish up. Remember my first talk, I said, you know, the U.S. is way out here on this line. Well, the reality is they're not really way out of that line until we get to about my age. You know, I think it's about 56 or 57, so I got a couple years. But you can see we as a country, we just go way off the scale once we hit that. And that's because we're not willing to ration health care. And I'm not saying necessarily that's a good or bad thing, but we're not even willing to discuss it. All right? Comes out death panels and everything else. So we as a country need to start looking at this, and we need to start managing these patients better. I don't know what happened to my slide back there, but anyway, all right. So it's going to require a shift, and I think, you know, here's David. David is quoted here on my slide, and so we need to look at a geriatric model. There's different type of patient, and we're seeing more and more geriatric. So we have to make our ED more geriatric friendly to perhaps keep them well or get them into a system, whether it's palliative or not, that will help reduce the cost of care. There's a lot of different things. I'm not going to go into all of these, but educating, training your staff, looking at follow-up calls, even changing your decor, the way things are presented in an emergency department, communication services, using large font. There's a lot of things. How many of you have actually a geriatric ED? You don't have one anymore? Not where you are? Yeah. Yeah, aren't they all? Yeah, okay. Good point, good point. I'm not going to argue that one. But I think we need to look at how to take care of this more efficiently. Because again, going back to that slide where we go off the scale, we're going to have to start managing these patients more efficiently. And so having an ED that meets their needs and can get them into a more coordinated system of care, family resources, other community resources, palliative care are going to be critically important. So again, key areas to transform the system, using efficient care, managing your ED length of stay, quality of care, improving the patient experience, and appropriate utilization. And I really see that as an emergency medicine, we are going to have to look out of our comfort box of acute care. We are going to have to start embracing other technologies, telemedicine. I think we're going to have to start embracing retail medicine into some regard because it's part of the population health management. And people are why are they using retail care? Why are they going to urgent care? Because their deductibles are so high, and our EDs are so burdened with overhead costs. We're going to have to maybe eventually look at a new model for lower acute care in our EDs to not put such a heavy, cost burden or overhead burden on that. And again, clinical guidelines. I'll go back to my first talk on the choosing wisely. I think clinical guidelines are going to be a key to helping us reduce costs. We're going to have some sort of safe harbor for using them.